Good morning, everyone. My name is Alberta Noonan, and I'm from the New England QIN-QIO, and I will be your moderator for today's webinar, Promoting Interoperability, Measures, Scoring, and Last-Minute Prep for MIPS 2018 Reporting. Before we get started, I want to review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation. We will take questions at the end of the presentation, and at that time I will provide you with instructions on how you can ask a question over the phone. You can also post a question in the chat box throughout the presentation. Please make sure to send that question to all participants. Today's presenter is Leila Walensky from the New England QIN-QIO. And at this time, I will turn the presentation over to Leila.
Thank you, Alberta. Good morning, everyone. Almost said good afternoon. I hope you are all having a great day, and thank you for joining us today. As Alberta mentioned, we'll be talking mostly, and actually all today, about promoting interoperability. And without further ado, I will get going. So quick disclaimer, this is content that we created here at the New England QIN-QIO. It is based on CMS content, but we did create it, so just in case there are any inconsistencies. A couple objectives for today. So we'll be describing the promoting interoperability measures, illustrating the promoting interoperability scoring methodology, and identifying the preparation tools and strategies you can use to do final prep for 2018 reporting. Just a quick reminder, there are 4 MIPS, which is the Merit-Based Incentive Payment System performance categories for 2018. The first is quality. That accounts for 50% of your MIPS score. You can report on up to 6 quality measures. One needs to be an outcome or high priority measure. There is the promoting interoperability category, which we'll talk about today. That accounts for 25% of your MIPS score. And in order to achieve a score in this category, you must report on at least the base required measures. There's also the improvement activity category. That accounts for 15% of your MIPS score. Depending on the size of your practice, you would be reporting on either 1 or up to 4 improvement activities in order to earn full credit in this category. And then there's also, new this year, the cost performance category. This accounts for 10% of your MIPS score. There are 2 measures under the cost performance category. The first is a Medicare spending per beneficiary measure, and then there's also the total per capita cost measure. Also, just as a little reminder, within the MIPS performance program, there are 2 thresholds to keep in mind. The first is that in order to avoid a negative payment adjustment, you must earn at least 15 MIPS performance points. And just as a reminder, this year in 2018, the negative payment adjustment for those that do not perform or do not submit any data would be 5% negative payment adjustment. I apologize, the text below that is very small. Just also a reminder, quality performance category data must be submitted for a full calendar year. Promoting interoperability and improvement activities is at least 90 days, and cost data is also a full calendar year. You don't actually need to submit data. CMS will pull your performance right from your claim. All right, so promoting interoperability deep dive. We're going to go into some more information about the category itself, and I'll actually talk about each of the measures and how you can prep for reporting depending on where you're at with your practice, what you're thinking are the priorities within the practice or the patient panel, and obviously try to get the most points possible so that you can maximize your MIPS payment adjustment. And I should also mention this doesn't necessarily only apply to MIPS. If you are in a Medicare Shared Savings Track ACO, so reporting under either an advanced APM, that's a Medicare Shared Savings Track, or a MIPS APM, the promoting interoperability category would also apply to you. You would need to submit data either as an individual or as your participant PIN. So just keep that in mind as well. All of this information remains the same. It doesn't change whether you're in an APM or under the MIPS track, but just know that ahead of time. So the MIPS performance category, of promoting interoperability, there's a total performance category score of 155 percentage points. This is actually wrong. We didn't include the 10 points for 2015 certified technology, but that's a little separate. So we'll go with the 155 for now. So 50% of that score comes from your base required measures. I will talk about those in just a moment. 90% can come from your performance measures, and then there's an additional 15 available for bonus. There is one other bonus component that we'll talk about, as I mentioned, if you are using a 2015 certified system. You are capped at 100%, so you can't actually get to the 155, but if you earn the 100%, you would get all of the performance category scores, which, as I mentioned, is 25 MIPS points towards that final MIPS score. You must report for at least 90 days. That is a consecutive 90-day period, and it can be any 90 days within the year. Obviously, you would want to identify a 90-day period where you have the best possible performance. So maybe that's the beginning of the year, middle of the year, end of the year. Just as a reminder, you must select a 90-day period that starts no later than October 2nd of 2018, so it's coming up in just a couple of weeks, because that is the last day to start a 90-day reporting period for the calendar year. Submission options available are attestation, which would be through the CMS QPP website, the portal, EHR Direct, which would be utilizing your electronic health record vendor to submit the data on your behalf, through a registry or qualified clinical data registry. They would also be submitting data on your behalf. Or if you're in a large group of more than 25 eligible clinicians, you could select the CMS web interface. We saw last year in 2017, most of the eligible clinicians and groups selected to report via attestation or going through the CMS QPP portal. You have an option there where you can either attest manually, where you go through and key in the numerator-denominator values for your various measures, or you can upload a report. You would either use the QRDA3 file coming right out of your EHR, or you could use the MIPS file if you were using a registry. Just as a side note, if you go attestation, so through the portal, that is a free method of data submission. So if you're looking at costs and whether or not you have the resources to maybe pay your vendor if you need a new module or need additional support, or getting registry access, that option is free versus a couple $100 potentially. So now let's talk about the measures. So the base score, as I mentioned, that's 50% of the total performance category score. So if you only reported on the base score, you could earn 12.5 MIPS points. As you remember, I was mentioning that you have to earn at least 15 MIPS points in order to avoid a penalty. So by just reporting on this category, you're almost there. You could report on one quality measure to get yourself over that 15-point threshold. As I mentioned, in order to accommodate the base score, you have to report on all of the required measures. So what that means is for numerator-denominator measures, so for the promoting interoperability measures, which are the 2015 certified EHR measures, you would have to have at least one patient in the numerator for the e-prescribing, provide patient access, send a summary of care, and request and accept a summary of care measures. If you don't have one in your numerator, then obviously you do not meet the requirements of those measures, and you would not meet the requirement of the base score. A side note to that is for the e-prescribing and 2 summary of care measures, there are in fact exclusions. So if you happen to have fewer than 100 permissible e-prescriptions during your reporting period, you would be excluded from that e-prescribing measure. That's both at the individual clinician level and at the group level if you choose to report as a group. If you choose attestation, there's a button you would click in the attestation window that says fewer than 100 permissible prescriptions or something to that effect, and grays out that measure entirely. The same is true for the summary of care measures. If you do not have 100 permissible referrals or transitions, and that depends on how your practice is handling those, then you would be excluded from those 2 measures, and you would want to go about excluding yourself from those measures in the same way. You don't lose any points or the ability to meet the base requirements. If you're excluded, you just wouldn't have to submit data for those 2 measures. I would just highly recommend you confirm that you are under 100. CMS does have the ability to audit any data that's submitted to them for up to 10 years. So make sure you confirm your patient populations and your performance before you select the exclusion to make sure it's actually applicable to you. If you do not say yes to the security risk analysis, which we'll talk more about in just a few moments, you would also not meet the requirements of the base measures. One less measure is required for the 2018 Promoting Interoperability Transition Measures. That set is available for practices and clinicians using 2014, Combo 2014, 2015, and 2015 alone certified EHR technology. The one measure that you do not have to report on is that request and accept, which is basically pulling the data from your summary of care document into your EHR and utilizing it that way. But you still have to send the electronic summary of care document under the Health Information Exchange measure. As I mentioned, failure to meet the reporting requirements for the base score would get you a 0, and you do not qualify to earn any additional bonus points or performance points on the other measures. For the performance score for the 2018 measures, so again, those are the measures available for individuals using either 2014 certified EHRs, 2014, 2015 combo, or 2015 alone. There are 7 measures you can select from, and this gives you the opportunity to earn up to 90 points. 2 of the measures, which should look very familiar to you, are actually part of the base score, and you earn double the points for those. So if you're doing well with Provide Patients Access, which are providing patients access to your portal, then you could get up to 28% bonus points here. And also, again, that send the summary of care document, that's also 20% possible points. There's still that view, download, transmit, again, coming from the portal. Does the patient have access to get into the portal and view, download, transmit their data? Patient-specific education recommended by the EHR based on the patient's diagnosis, conditions, other elements. Secure messaging to the clinician or care team, medication reconciliation, and immunization registry reporting. The immunization registry reporting is a simple yes, no, either you meet it or you don't. It's not a numerator denominator measure, and that is a straight 10 points or 0 points. It's not a percentage-based score. The Promoting Interoperability measures go for those using strictly 2015 certified EHR technology. These are very similar to the measures I just mentioned, but a couple extra. So you don't get the double points for the Provide Patient Access or Summary of Care measures. You also have the opportunity to do clinical information reconciliation. So that's pretty much the same as Request and Accept the Summary of Care, although it's not pulling the CCDA or continuity of care documentation in. It would be looking more at medical record information, anything coming from patient-reported outcomes, things of that nature. And again, that same immunization registry. Those are the performance measures. There are bonus points. The bonus points are for 5% bonus for reporting to a public health or clinical data registry. If you have the ability to send data to any of these, you can earn some bonus points. Whether you report to all 4 or 1 or any combination of the 4, you still are only able to get the 5 bonus points. If you select certain improvement activities that utilize your certified EHR, you can also earn 10 bonus points, and there are about 18 to select from. I also don't have it on here, but for those practices that are using 2015 certified EHR technology, they would earn an automatic 10% bonus for moving on to 2015 certified technology before it's truly required, which, by the way, will likely be next year in 2019 based on the proposed rule. So, how is your score calculated? The total Promoting Interoperability Performance Category score takes into account whatever points you earn for the base score, so it's automatically 50 because once you meet the requirements, you get the full 50%. Any bonus points you earn for performance score and bonus score, and then again, you're capped at 100%. So assuming you can get somewhere between 50 or more points between performance and bonus, you cap out at 100 and you'll get the full 25 MIPS points. Just as a reminder, for your total MIPS score, it's calculated by taking the performance category score times the weight of that category. So again, quality is 50%, improvement activities are 15. Oops, sorry, it still says advancing care information, that should be promoting interoperability, is 25, and cost is 10. You take the whole score across the board, multiply it by 100, and that gets you your final MIPS score. Again, you're capped at a total of 100 MIPS points, just like in each of the categories. Just as a quick example so that you can see how the score is calculated, I use the example, this would be someone utilizing a 2014 system, so they are using the 2018 Promoting Interoperability measure set. So if you go across, required would be the security risk analysis, so they did say yes, they completed it. E-prescribing, they had 289 patients of a possible 315, which gave them a 91.47. They didn't earn a bonus because that is not a bonus measure. For provide patient access, they had 247 patients of a possible 295, which gave them 92.88. This is a bonus measure, and since they were on the 2014 certified system, they got 20 points. If you go back and look at the score, it's 10 for 90 plus points. So they got 20 there. For health information exchange, they had 32 of a possible 198, and that gave them 16.16, which gave them 4 bonus points. Secure messaging, 230 of 295, 77.96, that was 8 bonus points. View, download, transmit, 261 over 295 for 88.47, that's 9 bonus points. Patient-specific education was 189 patients of 270, which gave them an even 70 and 8 bonus points. Medication reconciliation, they had 200 of 278, and that gave them 71.94 and 8 bonus points. And they did take the improvement activity use of certified EHR technology, which gave them 10. So as you can see, their base score, they got the automatic 50%. If you take all of their performance bonus, which will be the 20, the 4, the 8, the 9, the 8, and the other 8. They came out to 57% of a bonus score. And then they took the 10% bonus for the improvement activity using CERT, which gave them, as you can see, over 100 points, so 117. They're capped at 100, so they took the full 25 MIPS points. This would be the same, just slightly different measures and different percentage bonuses for the 2015 option, if you're using the straight promoting interoperability measures as well. Just as a reminder on the actual scoring, so for MIPS, if you earn 0 performance points, you would take a negative 5% payment adjustment this year. That's off all of your Medicare Part B claims. If you earn 15 performance points, you would get a neutral, so no payment adjustment, positive or negative. A performance score of 16 to 69 MIPS points would give you a small positive payment adjustment, and anywhere over 70 MIPS points would earn you a modest positive payment adjustment and the opportunity for the $500 million exceptional performer bonus. Now, don't get too excited. You won't get that whole pool. You do qualify for some of it based on your performance, and however, many other clinicians also earn that bonus. Definitely the area you want to get into. Before I dive into the measures, there's a couple elements I want to highlight. These are really critical if you have different types of staff working within your practice, or maybe you yourself are one of these different types of clinicians. So there's a special status determination. If you go on to the qpp.cms.gov website and use the QPP participation lookup tool, you would see that certain statuses are identified. So on the screenshot I have here, I'm showing down at the bottom, special status is noted as hospital-based yes. There are several different types. So there's hospital-based and non-patient-facing clinicians that would show up here. These two clinician types, along with physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists, would qualify for automatic reweighting of the promoting interoperability category. By the automatic reweighting, that means that the 25% score of that category automatically gets moved to the quality performance category score. So promoting interoperability becomes 0 and quality gets reweighted to 75%. As you can imagine, if that reweighting takes place, it's critical that you do well in quality because it makes up such a large percent of your score. I will also note there's a key important detail here for the reweighting. If you're in a practice of multiple clinicians, some hospital-based, some non-patient-facing, and you're reporting as a group, you don't automatically get the reweighting. If you're in a practice that is at least 75% non-patient-facing clinicians, then your whole practice would be reweighted to 0 for promoting interoperability. If it's below that 75%, then you would still be expected to report on the category as it stands normally. For hospital-based clinicians, you have to be in a practice that is 100% hospital-based clinicians. If there are any clinicians that are not hospital-based within your practice, unfortunately, you do not qualify automatically for the reweighting. So just keep that in mind as you're planning and preparing for reporting. This will also tell you on the website if you as an individual qualify as a hospital-based and non-patient-facing clinician, as well as your practice. So you don't really have to guess, you know automatically whether you qualify for the reweighting. Another question we hear a lot, and it is now available, is there a hardship exemption? So yes, if you are in a practice or you yourself as a clinician are experiencing significant hardship and unable to report on the required measures for the promoting interoperability category, you can submit a hardship exemption application. This is what it looks like. It's available on the qpp.cms.gov website. If you go under the MIPS tab and then select Promoting Interoperability, you would find the application. Some of the reasons for submitting this application include insufficient internet connectivity, extreme and uncontrollable circumstances, and lack of control over the availability of certified EHR technology. There's also hardship exemptions for clinicians in small practices, so you could also fill this out if you're in a small practice. Now, that doesn't mean simply because you're in a practice of 15 or fewer eligible clinicians, you will get the hardship. It's more that you're in a small practice, you don't have the resources necessary to implement the required technology, or you're struggling with the technology. There really needs to be a reason behind why you're struggling beyond just being a small practice. So keep that in mind as you take this into consideration. If you have any questions, aren't sure, I would highly recommend you submit the application. The worst thing that's going to happen is CMS will decline it, but if they accept it, then you would have, the category would automatically be reweighted to 0, much like the special status, and quality, again, becomes 75% of your score. So, and I should also mention, I don't have it on here, the hardship exemption form must be completed by December 31st of 2018. So you have about 3.5 months to get that taken care of. All right, so the promoting interoperability category is comprised of several key components: patient engagement, care coordination, interoperability, and public reporting. Each of the measures falls into one of these categories. The first measure, which we get lots of questions about and can often cause a lot of issues, and I have a wrong date on there, the security risk analysis. So you are expected to complete a security risk analysis at least once per calendar year, or if you implement any sort of new technology or upgrade your system, you need to look and make sure that the system is secure. Again, it's looking at encrypting data, making sure all of the security updates are in place, identifying any issues, discrepancies, deficiencies, having a plan in place to mitigate those issues and protect your patient's data. E-prescribing, this one's pretty straightforward. So each clinician or practice must submit at least one permissible e-prescription. The issue with this oftentimes comes into what's considered e-prescribing. There used to be questions about durable medical equipment and whether those scripts, although they were prescriptions, did they count as e-prescribing? Unfortunately, they oftentimes do not. It's also dependent on your state laws. Some state laws do not allow for the e-prescribing of Schedule II narcotics, but nonetheless, more than likely, clinicians have more than enough e-prescriptions going out to their patients to qualify for this measure, unless you maybe are a specialty provider that does not see many patients and does not send out any prescriptions at all. We highly recommend working to implement medication management techniques. Obviously, there is a tremendous opioid crisis going on in the country right now, so it's really important to look at how you can improve prescribing habits, make sure that patients are getting the care that they need and the medications they need when appropriate. Provide patient access. So for at least one unique patient, eligible clinicians need to provide that patient or their authorized representative. We get questions a lot about what if I have a patient who maybe has severe dementia and they have a family member taking care of them. You would want to provide that family member with appropriate access, and they would count under this measure. And they just need to have access and be able to get into the portal that you have set up for your practice. And then hopefully you're pushing information out to the portal, such as after visit summaries, medication lists, the ability to request appointments, prescriptions. The great thing about this measure is it's a base and a performance measure, and you can get bonus points for using portal utilization as an improvement activity. Health information exchange, as I mentioned, this is sending at least one transition of care or referral and having that electronic summary of care record available. This covers a lot of different areas, tremendous opportunity for care coordination. It's a base measure, it's a bonus measure, and through the bilateral engagement and closing the referral loop, you can take additional improvement activity credit, and there's also the closing the referral loop quality measure. So it really hits all three of the performance categories in one. Great way to earn some extra points. Send and accept a summary of care. This is very similar to the previous measures I mentioned, but you would want to take into account the patient's record and then retrieve and incorporate it into your record in a meaningful way. Same base performance, opportunities for additional care coordination and engagement. Medication reconciliation. So this is much like the other measure, but just looking at medication reconciliation. The clinician performs medication reconciliation at a transition of care. So these are usually new patients coming into the clinician. This is a great way to ensure that the patient understands their medications, they have the correct dosing, they actually know what they're taking it for. It's an improvement activity for bilateral exchange of patient information. It is a bonus measure because you're utilizing your EHR as an improvement activity, and there is a quality measure as well, medication reconciliation post-discharge, so you can get some additional bonus points there. Clinical information reconciliation, much like medication reconciliation, pulls in multiple components of clinical data. So for at least one transition of care or referral, that clinician would pull into the record the medications, so you're reviewing patients' medications, checking the dosage, frequency, route, reviewing medication allergies and any other allergies the patient may have, and then, of course, updating the problem list. This is a great way to make sure the patient's problems, current or past, are correct, and engaging the patient in their care. This covers, again, multiple areas of performance. There is the improvement activity for bilateral exchange of patient information. It is an EHR utilization improvement activity bonus. And again, there's that closing the referral loop quality measure. If you happen to be the referring or consulting physician, you can take credit for it. View, download, transmit. This is a great way to get some points. So for at least one patient seen by the MIPS eligible clinician during the performance period, you would want to make sure that they have access to their portal and can view, download, or transmit their health information. Pretty simple. Great way to get some bonus points. Anything related to the portal, I think, is an excellent way to get a lot of points taken care of pretty easily. So portal utilization, as I mentioned, is an improvement activity. There's methods within this that help you engage patients in their care. So obviously you can communicate with them in a more bidirectional manner once they're not in the office. And then there's also multiple opportunities for increasing performance. So again, engaging patients and family caregivers in their plan of care, and then it's an EHR certified EHR utilization bonus for the improvement activity category. Secure messaging, much like you download transmit, for at least one patient seen by the MIPS eligible clinician during the performance period that they send. And so this is an interesting one. The patient actually has to send you a message. A way to get this to work, and we've seen this happen before, is that sometimes practices will send a tickler message out to patients saying you have a new alert on your portal, or flu season's coming, right? In the next couple weeks, flu season's going to hit. Come get your flu shot. Sign into the portal to request an appointment. So you kind of prompt the patient or the patient's representative to take action. And it's a great way because they see that there's a new alert, they automatically sign in, they want to make sure they're not missing anything, so they send you a message right back. Great way to take care of it. Also, if that's more of a challenge, talk to the patients about, send me a message once you log into your portal just to make sure you've seen everything. Just shoot me a quick message saying, yes, I saw my ask for visit summary, no questions. Or review it and then send me a question, or whatever the case might be. But a great way to start the communication lines with your patients or continue in them. Again, improvement activity with portal utilization, great way of increasing patient engagement, and it covers that developing into just individualized care plans, and you get the EHR bonus. Patient-specific education, much like their messaging. So for each MIPS-eligible clinician, they use clinically relevant information identified by their certified EHR technology to provide resources to those patients. So it's, again, looking at diagnosis-related education or medication-related education, or perhaps the patient identified a social determinant issue where they need help with transportation, so you provide education around those elements. But it has to be identified by your certified system and then provided to the patient through the portal. Again, portal utilization, great way to increase that, covers multiple areas. So hello, can anyone hear me?
Yes, I can hear you now.
Okay, perfect. I don't know what happened. I had to close out and log back in. I'm so sorry about that. Sometimes technology doesn't work in our favor. I apologize.
Great.
All right, so let's keep going. A few more slides. So for patient-generated health data, I don't know where it died, but this is patient-reported outcomes. So if you have a patient with diabetes or congestive heart failure, oftentimes the clinician will ask the patient to send in information about their finger-stick blood sugar levels at different times of day, or what their weight was if they had CHF. So patient can send that in through the portal, and then the clinician would want to pull that into their EHR system as a patient-reported outcome to show that the patient was monitoring those different conditions. This is a great way to identify methods for improving the longitudinal care plan for high-risk patients. You want to make sure, again, to engage your patient, engage the family members, make sure they know what they need to be doing, and how to keep that patient out of the hospital if possible. Registry reporting, I'm not going to get into too much because it all really depends on where you're located in your state, what's available, what your specialty is, but there are various different opportunities for immunization registry, syndromic surveillance registries, electronic case reporting, public health, clinical data, and then specialized registries based on your specialty, potentially. Again, those are bonus measures. You would get 5 points bonus for syndromic surveillance down. Immunization registry is a 10% weight performance measure for both categories. It just depends on if you're able to send data or not. All right, quickly, as I mentioned, for those participating in an alternative payment model, if you are in a MIPS APM or advanced APM under the Medicare Shared Savings ACOs, you would be reporting and promoting interoperability performance under your APM participant TIN. So that is performance weighted by the number of clinicians in the TIN, and then that TIN score gets aggregated to the APM entity score. If you are in an advanced APM under the next generation ACO, there's no promoting interoperability reporting required. The APM entity must attest that at least 50% of the participants are using EHR technology, and that covers the attestation requirements. Quick couple updates about the 2019 proposed rule, which is currently in active rulemaking and comment period. So, if you haven't already heard, there is an increase to the performance threshold. 2018 is currently 15 MIPS points. 2019 is looking like it'll go up to 30 MIPS points to avoid a payment penalty. There's also a change to the low volume threshold. CMS is considering adding a third component, which would be the number of professional services billed for. And that, much like the patient seen, is also at 200. So in order to meet the eligibility criteria above the low volume threshold, you would have to submit more than $90,000 in Medicare Part B charges, and again, those are coming right from the physician fee schedule. You would have to see more than 200 eligible Medicare beneficiaries annually, and you would also have to bill for more than 200 professional services annually. So 200, 290, all above, you would be included. If you're below on any one of those, you would be excluded. So now there's a third component potentially excluding you. There is also consideration for an opt-in if you meet one or two of the components, but not all three. You might be able to opt in and participate and earn an incentive. But again, this is all still under proposal, not sure what will get finalized. As I mentioned, there is proposal to require the use of 2015 certified EHR technology. Under the cost performance category, there is proposal to add an additional 8 episode-based cost measures. There's still a small bonus for clinicians in small practices. That would be 3 additional points for your quality performance category numerator if you are in a small practice. There's also proposal to make claims-based reporting for quality measures only available for clinicians in small practices. There is also consideration to go from only allowing that for individual small practice clinicians to allowing it for group small practices. Clinicians that are considered to be facility-based, so they would be hospital-based, they have the opportunity to use their facility-based score on the value-based purchasing as their quality or cost performance category performance, if they would like. And then there's also still some opportunity for bonus points under the improvement that you show in the quality performance category. Many more changes. Those are just sort of the high level. Think about them, chew on them. If you have any major concerns or really appreciate these changes, I would highly recommend you submit a comment. Comment period is open until a couple more days, September 10th, I believe. So coming right up, so make sure you get that comment in if you have any thoughts about it. This is my puppy, Max. He's going to be 4 next Tuesday, so I figured I'd show him off because he's so handsome. And we will jump right into questions. I'm going to go just one slide further so you have my contact information if you would like to send an email. And I think there's some questions. Let me just scroll up in chat. Let's see, lots of questions about the slides. No, it looks like everyone just couldn't hear me. Oh, here's the question. Okay. Other than using EHR Integrated Patient Portal, are you aware of any ways to meet the Provide Patient Access measure? So, yes, you could use, depending on if your EHR or your system has an application programming interface. Some of them now have APIs that you can utilize. But again, it's really based on the technology available within your system that can work with your EHR. It can't truly be a standalone because, again, you have to integrate elements of your EHR data. So it's key to pull that information in. Yeah, Max, he's silly, isn't he? All right, let's see, another question. For HIE summary of care, how does the EHR determine what a permissible patient is for the case minimum. For example, for specialist optometry, who does not have a lot of referral patients who are not on a shared HIF, what does that mean? The fact that they will need to meet the case minimum. So honestly, it would really depend on a lot of different things for this practice. You're right, they wouldn't have many referral patients, but the key here is it's not strictly referrals, it's referrals and transitions. So a transition is moving a patient between different settings of care. So in fact, you could think of the transition of if an optometrist is seeing a patient and that patient then goes to their primary care provider, then theoretically that optometrist should be sending a summary of care back to their primary care provider because they're transitioning the patient back and forth between settings, and you want to make sure that any care that was provided, especially to diabetic patients, other patients with chronic diseases that need to have those managed, that all of that information is getting shared. So not necessarily always referrals, but important to think of referrals and transitions. And transitions really are that transition between different settings of care. All right, another question. Please clarify, is it just the next generation ACO that does not require reporting promoting interoperability? So, yes, in New England, we have limited additional advanced APM models, so I don't typically go into those because they don't apply to the population that we address here in New England, but there are potentially other advanced APMs that would not be reporting promoting interoperability. I would highly recommend you check on the CMS website. They have some great resources, and that would have all of the information related to what APMs must submit promoting interoperability. But for the models that we handle in New England, next generation ACOs are the only ACO APM track that would not require promoting interoperability submission. Clinical summary, health information exchange, are you excluded if you refer out less than 100 patients? Yes, that is true. I can't seem to reconcile this in our practice situation. I'm not sure what you're referring to in terms of reconciling it. So it's referrals, again, and transitions, so just be cautious of that. Every system calculates this a little differently. Oftentimes it's based on referral or transition orders. We've had issues where we've worked with practices that are not accurately capturing their referrals or transitions because of workflows that were developed many years ago. So just be cautious about how you're calculating and capturing the data because it is transitions and referrals, not just referrals. If you'd like to ask questions over the phone, I believe it's #6 to open the phone line, or you can ask them in the chat. While we wait for more questions, there's a couple of resources that I want to provide to you all. So we have a New England QIN-QIO macro website. It's neqpp.org. You can ask a question there. You can also go to the qpp.cms.gov website. This is the link to the participation lookup tool that I mentioned, or the portal, or the resource library, lots of information. I believe slides will be made available after the presentation on our website.
That is correct, and I'm going to post the link.
Excellent, thank you. I see a question here. Do chiropractors and physical therapists need to report MIPS? Chiropractors, yes, if they meet the patient threshold, so that low volume threshold with patients and claims. You would definitely want to check your clinicians under the MIPS participation lookup tool. Physical therapists are not currently included as eligible clinicians for 2018. It is proposed that they will be included in 2019. The caveat to that is if you report as a group, so your whole group is reporting, then every clinician in your group, all of their data would be pulled in. So a physical therapist would also get pulled in. They just wouldn't be eligible for a positive payment. Let's see, one more. Same question. Do you have recourse if your EHR underrepresents your performance? Wow, great question. I'm really hoping that that's not a real life example and that your EHR did not underrepresent your performance. I would highly recommend that everyone that's planning on using their EHR data reviews their data prior to submission so that you're looking at all of your numerators and denominators for your measures, that you do that gut check to make sure that they look correct. Typically, the measures related to the portal should all have roughly the same denominator, maybe slightly different numerators, but they should all be roughly the same. So if you see very different performance on those measures, you know something probably isn't correct. But then again, if you're seeing that your performance is drastically different than what you expect or previous reports that you run, I would get in touch with your EHR and make sure that there isn't something broken in the report. In terms of them underrepresenting your performance, I guess theoretically under your contract with the EHR, you could go after them, but not under the MIPS program. There's no way to go at your EHR vendor if they're underrepresenting your performance, unfortunately. Okay, in doing these referrals, do they have to go through the EHR, or does it count to send via fax? So they wouldn't necessarily have to be referred directly through your EHR, but there would have to be an order to signify that a referral or a transition had taken place. So some practices can accept EHR direct referrals. You would need to still fax that, but you would need to make sure that there is a way to track it within your EHR, which would be through typically an order of some kind. Let's see, back to the HIE. If the referral partners are not accessible via the HIPS, the practice does just give them a pass. Unfortunately, no. This has been the age-old issue with these types of measures. Even if you don't have partners, I'm using air quote partners, to send referrals or transitions to, you are still expected to get that summary of care document to them. This is why this measure plagues people, is a very unpleasant measure, I'm going to say, because there just are not accessible resources in many cases. Finding direct addresses can be extremely difficult. They're not maintained well. It's a challenge. So unfortunately, just because you don't have access to the HIPS does not give you a pass. One final thought before I'll stay on the line for another 9 or so minutes. We are on social media. If you have questions, interests, feel free to follow us on Facebook, LinkedIn. We're also on YouTube and Twitter. We don't have those up here, but feel free to follow us. I'm going to go back to my contact information if you have any additional questions or want to give us a call. If you're struggling at all looking at your practice data, need help, feel free. Just as a reminder, the final 90-day reporting window for 2018 begins October 2nd. So if you haven't done anything yet, you still can be successful. We are here to help you and make sure that you do not get a 5% negative payment adjustment. So feel free to reach out to me and my team. If you are in New England or really anywhere across the country, feel free to reach out. I'm happy to connect you to the appropriate contact in your state or region. But we definitely want to make sure that everyone avoids that penalty if possible. And thank you again for being on the call.
And I'd also like to interject, when you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you'll receive an email tomorrow with the link to the evaluation, as well as a link to the event page on our website. The slides are available on the event webpage, and within the next few days, a recording and transcript of this webinar will also be added. And I've put that link in the chat box for you again. If you have, and Leela will be on the line for another 8 minutes to answer any last questions you have. Thank you.
Alberta, can you help? It looks like the link to the slides isn't working.
Okay, let me see what's going on. Yes, it looks like it's not posted at the moment. I will have our communications department work on that this afternoon, and it should be posted by 3 p.m.
We have a few more minutes. If you have any last questions, feel free to ask them in the chat or over the phone. Again, it's pound 6 to unmute your line. So question, clinical summary and health information exchange. We are a small GI practice. We refer out much less than 100 patients. Can we take an exclusion? So I can't say for sure that you can take the exclusion. Again, it's not strictly referrals, it's transitions. So I don't know if your practice is seeing patients and then transitioning them back to their primary care provider, but that would also be taken into account. So again, it's not, those two measures are not strictly referrals, it's referrals and transitions. So keep that in mind as you get to your 100. The other thing to keep in mind is, as a practice, if you're reporting as a group, it's the total of all of your clinicians coming together. Do they have over 100 during your reporting period or less? If there's less, then obviously you can take the exclusion. If you're reporting as individual clinicians and they all have fewer than 100 referrals and transitions, then they would also be able to take the exclusion. All right, I see one more question, and then we are at time. Is the reporting period for 90 days or a year? The reporting period for promoting interoperability is 90 days at least. You can definitely report for a full year if you want to and you have the data, but it is required as 90 days. And we are at time at 12:30. Thank you again for participating today. If you have any additional questions, please don't hesitate to reach out to us. You can contact me directly via email, or you can go through our website, which is neqpp.org. We have an Ask a Question link there. Thank you again. Have a great rest of your afternoon.
User has disconnected. The conference will be terminated in 5 minutes.